At the onset, I would like to thank the organizers for selecting our work on metabolic risk factors and prevalence of PLIN gene among children initiating ART in this meeting. As we know, ART causes overall reduction of morbidity and mortality in not only adults living with HIV, but also children. It can also lead to development of metabolic syndrome or the HIV-associated lipodystrophy syndrome, characterized by abnormal lipid profile, insulin resistance, and body fat redistribution. Despite the similar exposure to drugs, diet, and socioeconomic status, not all children started on ART develop metabolic syndrome. There's a definite role for host genetic factors. Polymorphisms in ApoA5, ApoC3, ApoE, and CETP have been shown to be related to lipid abnormalities. Dr. Odovas and his group from Tufts University School of Medicine, Boston, have shown perilipin gene, otherwise known as PLIN gene, which is a major protein coating the lipid droplets and modulating the adipocyte lipolysis, to have a definite role in metabolic syndrome. The minor allele at PLIN 11482 is associated with higher risk of metabolic syndrome not only in white women, but also other ethnic population, especially in Chinese and Asian Indians, where they found a higher triglyceride levels, lower HDL cholesterol, and higher insulin resistance. As we move on with more number of children starting ART in India, there's no study looking at the interaction of diet, drugs, and the genetic factors on these children starting ART and the lipodystrophy syndrome. Currently, there's a prospective study ongoing at the National Institute for Research in Tuberculosis, Chennai, and St. John's Research Institute, Bangalore, where children initiating ART between the age of 2 and 12 years, with the present national guidelines on first-line ART, they're looking at the incidence and the risk factor for development of dyslipidemia, insulin resistance, and body shape changes. We wanted to assess the baseline risk factor of metabolic syndrome in terms of lipid profile, glucose, insulin resistance among these children before they initiate first-line ART, and to look for the presence of polymorphisms in the gene associated with metabolic syndrome in these children. The data was collected on anthropometry, body circumferences, including the chest, waist, and hip measurements, skin fold thickness from triceps, biceps, suprascapular, and suprailiac. 24-hour dietary recall and food insecurity was assessed. Fasting blood for serum lipids, glucose, insulin, CD4 cell count, and viral load was measured. Gene polymorphisms done by RT-PCR, and insulin resistance was calculated using the HOMA score. 218 children with HIV, the age group of 2 to 12 years, with a mean age of 8 and mean body weight of 18 kgs are recruited. 60% of them were in WHO clinical stage 3 or above, 16% co-infected with tuberculosis. 97% of them had got the infection through vertical transmission, and 40% of these households the children belonged to were food insecure. All the children were on triple drug therapy with 2 nukes and 1 non-nuke. Many of them, 48 of them were on stavudine-containing regimen, as the stavudine was phased out from Indian protocol. They started on AZT, 154 kids on AZT regimen, and 16 on abacavir-based regimen. Looking at nutritional indicators in these children, stunting, which reflects past shortage of food or chronic illness, which irreversibly affects the organ growth as well as cognitive function of the children, 56% of them were stunted, the height for age Z-score being less than -2 standard deviation. Approximately 60% of them had weight for age Z-score of -2 SD, showing almost moderate to severe malnutrition in this group. Now, talking about the risk factors of metabolic syndrome, the fasting blood lipid level, all the parameters was below the normal range. Hypercholesterolemia seen in majority of the children. 87% of them had a low HDL cholesterol. However, 37% of children with HIV had a serum triglyceride of more than 150 milligram, the higher level of normal. Fasting glucose and serum insulin was within the normal range in this group, but 13% had a HOMA IR score of more than 3.5, and 22% had a C-reactive protein between the range of 3 and 10, considered to be high risk for metabolic syndrome. Now, looking at just the PLIN gene polymorphism, the homozygous group GG as compared to the minor allele A, GA, and AA, with respect to age, weight, and base circumference, both the groups were similar. However, the serum triglycerides, the group with the minor allele A was associated with higher triglyceride level at baseline as compared to the homozygous group, and this difference was statistically significant. So even before ART initiation, there's considerable amount of risk factor for metabolic syndrome in these HIV-infected children, with 37% of them having a higher triglyceride level, almost 90% with a low high-density cholesterol, and 13% with a homoinsulin resistance. In this cohort, the minor allele A at PLIN4, which is associated with increased risk of metabolic syndrome, was seen in 55% of the children. At baseline, those who had a raised triglyceride, 68 had minor allele as compared to 46% who had the normal triglyceride levels. We also looked at the other polymorphism of PLIN 6209 and 13041, which is supposed to be associated with obesity-related phenotypes, and we did not find any significance in this cohort. So to conclude, despite the background of food insecurity and moderate to severe malnutrition in our children, substantial number of HIV-infected ART-naive children are at high risk for developing metabolic syndrome. Given the relatively large number of carriers of genetic risk variants, children with advanced disease need to be closely monitored with lipid profile, glucose, and insulin levels for the development of metabolic syndrome once ART is initiated to prevent long-term morbidities. The study is currently ongoing. These children are being followed up for a period of 2 years with periodic monitoring of anthropometry and blood lipid levels. I would like to acknowledge all the study participants, the caregivers and their parents, my team, and I would also like to thank my mentor and the principal investigator of the study for letting me present the findings in this august audience, and the collaborators at Tufts University, St. John's Research Institute, Bangalore, and Indira Gandhi Hospital, Bangalore. And last but not the least, the sponsors of the study, NIAID and Indian Council of Medical Research. Thank you.
This paper is open for discussion.
Hello, Pablo from Spain. I didn't see if you had a control group of non-HIV infected children, because that would be important to know if that is associated to HIV or not.
In this study, we have not included a group of non-HIV infected individuals. But that's a point well taken. Yeah, maybe we should have to see the baseline metabolic syndrome in that group also.
I think it's important because it's difficult and we struggle to get non-HIV infected patients to compare, but I think it will be great.
Okay, thank you.
I'm Jacqueline Balunji from Uganda. Thank you so much for your presentation. You said that only 60% of the children were immunized up to date. I would like to know why that was so, if it's reflective of the national picture, or is it health workers maybe are more concerned about providing ART and not finding out if children are immunized? Thank you.
All these children were questioned about the immunization once they enter the ART center. So as for the data collection is concerned, yeah, all of them were asked the question of whether immunization was done or not. The thing is, many of these deliveries happens in the villages where they may not have access to immunization. And few of them were from the foster care, and few of them were also from the orphanages and home where they do not have the previous medical record of these children. So there's also a percentage of unknown in that. So we asked them whether they're immunized, completely immunized, or unknown. So many of them could have been unknown, and we did not include the unknown in the 60%.
I have a question. Thanks for the presentation. One of the points that you have been pointing out, it is that this patient could be more at risk of having heart-related toxicity or metabolic syndrome. Did you already follow them prospectively to see whether those who were on ART, maybe on PI as compared with non-RTI, were at higher risk of developing metabolic disorders, those with the allele versus those who were negative for the allele?
Yeah, so this is a prospective study.
Yeah.
And children are being followed up. They'll be followed for the next 2 years. And the blood lipids are done every 6 months, and anthropometry is being done every 3 months. So they will be followed up to see for the development and compared between those who had the allele and those who did not have the allele to see what happens.
Okay. Thank you very much.